cases that lately, almost 20 days or 3 weeks ago, we have managed. This is a 47-year-old female who is an obstetric and gynecology physician practicing here in Al-Madinah Al-Munawwara. She presented to my clinic 10 days after her history started. When she came to the clinic, she said in her own words, she had a very severe headache that was the worst pain that she ever had in her life. And this was immediately associated with nausea, and she was having severe dizziness to the degree that she could not stand up from the ground. And she said, أنا افتكرت نفسي بأموت وأحتضر. She felt like dying at that time. So what she did, her husband took her to the hospital that she works in, one of the hospitals in the region. They saw her, her friends, the emergency department, the medical department. They evaluated her and then they reassured her and sent her home. Yes, imagine they reassured the patient and they sent her here. So here we can stop and ask R1. Do we have R1, first year residency? What do you think about this history? What is characteristic about this history?
So,
hello. So it's saying that it's the worst headache she's ever experienced, with dizziness or alarming features.
Alarming of what?
So the worst headache, as the topic, so these are red flags. So worst headache, spontaneous, or alarming for, let's say, subarachnoid hemorrhage.
Yeah, is it because the title of our presentation is Subarachnoid hemorrhage?
No, it's because it's, as you said, it's one of the worst headache of the life, spontaneous, acute, associated with nausea and dizziness. So these are all red flags that you have to.
I agree with you.
Thunderclap headache.
And actually, in the medical school, كلنا into أنا and those students who we teach in the medical school, year 3, we tell them that the classical presentation, you find it written in book, worst headache that the patient had in their life. So imagine this patient was sent home. It's not only that, but she was given a sick leave. She stayed at home. She was feeling a bit well, not that sudden severe headache that she experienced. And 2 days later, she had the same attack of sudden severe headache. She couldn't stand. She stayed for some hours at home, and then her husband took her back to the same hospital. They again made laboratory investigation and they sent him home. Well, when she went home, she was clever enough. She is highly educated, a physician. So she went by asking in another hospital, and at the end, she ended in my clinic. Now, another question. Any of the emergency room physician could have done a physical examination to evaluate whether this patient might have blood or not. I mean subarachnoid hemorrhage. خلينا برضو مع اللي هم R1, R2, please. Physical examination. What do you think?
Go ahead, Ali.
Assalamu alaikum.
Alaikum assalam wa rahmatullahi wa barakatuh.
So in these cases, physical examination can reveal some meningeal irritation, so we can figure out if there is any meningeal sign in these patients.
Excellent. So you mean meningism?
Yes.
So give me one example. What sign?
Kering sign.
Kering sign. Yes. Which is?
which is the elevation of the leg, will cause spontaneous neck elevation of the patient.
Right, excellent, Ali. Let's pretend that this patient had a Koenig sign, Brzezinski sign, neck rigidity and neck stiffness, and severe neck pain on bending her neck. But the neurology department told you that this is meningitis.
Okay,
so what additional can be present in the patient, and you will say to the neurologist, لو سمحت, this is not meningitis, but it is subarachnoid hemorrhage, most probably.
Yes, I will look for another signs and symptoms of infectious process like fever, also the onset of the symptoms. You said that the headache is sudden, so most likely this symptoms related to vascular origin.
I agree. So this patient to the clinic, and let's say that she presented to the emergency room, and one of you who are attending our discussion tonight is present in the emergency room. So what do you think has happened? غير الدكتور علي, what do you think has happened to this patient? What do we call this situation? She had bled once, but her clinical condition, she was, let's say, stable, apart from the pain. She did not have deterioration in the level of consciousness. 2 days later, she had another also severe headache, but she was still full conscious level, no neurological deficit. So what do we call these, let's say, attacks?
We have some comment on the chat, rebleeding, genital bleeding.
Yeah, but it has a specific name. We call it sentinel hemorrhages. And these are very specific of small leak from an aneurysm that did not fully ruptured and give the last attack that the patient will definitely be admitted with. So these are warning signs, sentinel hemorrhages, that we should take it as serious. Otherwise, the patient might present with the devastating last issue, subarachnoid hemorrhage, that might have all the complication that will follow. Now, from the history, from the examination, we said that the patient has subarachnoid hemorrhage. But what are the underlying etiology of spontaneous subarachnoid hemorrhage? احنا قلنا في عندنا اثنين. الأول traumatic, and then we said this is separate entity. And we have the spontaneous. So other causes of spontaneous subarachnoid hemorrhage, number one is aneurysm, and most of the cases, up to 80% of subarachnoid hemorrhage coming with this presentation is due to cerebral aneurysms that rupture. Vascular malformation, especially arteriovenous malformation and cavernomas, they can present with subarachnoid hemorrhage. Cases of hypertension, blood diseases, and I have seen personally sickle cell disease cases presenting with subarachnoid hemorrhage. Medications, anticoagulants, and aspirin, especially those patients who are above, or individuals above 40, and they were advised to start on aspirin from their cardiologist. So we have to take a very good, proper history, and an entity that is called non-aneurysmal peri-mesencephalic hemorrhage that we need to stop for a while here and discuss. In addition to tumor and spinal AVMs. Spinal AVM, if it is present in the vicinity, let's say thoracic or the cervical level, if they rupture causing subarachnoid, spinal subarachnoid hemorrhage, it can ascend to the cranium and present with headache. And that's why, if you could not find the cause also about the other symptomatology of final AVMs. Now, non-aneurysmal perimesencephalic hemorrhage is a separate entity. How can you diagnose it? How do we diagnose non-aneurysmal perimesencephalic hemorrhage? Is it diagnosed in the emergency room, diagnosed by history?
Anyone from the junior?
Yes.
So, binding, and we usually have a negative CTA and DSA in these patients.
Yeah, so excellent. So in other words, you are saying that this is not a prospective diagnosis. مو لما نيجي للمريض في الطوارئ, I will say immediately, this is a perimesencephalic hemorrhage of an aneurysmal origin. But it comes after.
Yes, I agree.
Yeah, so it comes after a full investigation, and then it's a retrospective. We did not find anything, but not on the initial investigation. After the full investigation, including the digital subtraction angiography and the 3D DSA or 3D digital subtraction angiography. Now, we knew that this patient, from the symptoms, from the history, she had a subarachnoid hemorrhage, or the typical history of a subarachnoid hemorrhage. So we will usually start by doing the proper history, the proper examination that we have just mentioned. We should stabilize the patient, because not all of them will arrive in a stable condition, but some of them might be unconscious. Some of them might need immediate intubation, and some of them, as we will mention later, might have attack of seizure that have deteriorated their level of consciousness. So stabilize the patient condition. Now, what laboratory investigation are important in a case of subarachnoid hemorrhage?
Coagulation profile.
Well, coagulation is to rule out, as we said, one of the causes of subarachnoid hemorrhage, but this, you can take it from the patient history, صحيح? So he's not using any anticoagulants. He doesn't have, for example, renal failure that he is on a dialysis necessitating the addition of heparin each time he comes to the dialysis. What else? Lab.
Not sure actually, except of the CBC. I need to know how active is the bleeding, and I need to know, to make sure one of the measures to treat the subarachnoid hemorrhage is to make sure that the patient is not anemic.
You just said one word. You want to know the CBC to check on the severity of the subarachnoid hemorrhage.
Yes.
Do you mean hemoglobin level?
Yes.
The rest of the 90, do you agree on this? And think between you and yourself. Now, Dr. Dania, if the patient hemoglobin level has dropped, let's say he was 15, he was 15 and now he is 10. Do you think that the bleeding is in the head?
I would think again, sorry.
Do you think it is intracranial?
Actually, less likely, I guess.
ليش? Why is that?
It will be, if it's intracranial, it will be more contained. The drop in hemoglobin will be less. I'm not sure, actually. I'm just guessing.
Yeah, I agree with you. Excellent. So let's take it as a standard that apart from the subarachnoid hemorrhage, let's say about the trauma patient, and you will be called in the emergency, and the other departments are saying that hemoglobin has dropped and he has an epidural hematoma or an intracerebral hemorrhage. Always, it cannot be the cause of the drop in hemoglobin, and they should look for other regions like intrathoracic, intra-abdominal, the thigh, and so forth. Why? Because the intracranial compartment is very contained. A very small amount of blood will cause the symptomatology. And if it is the same amount that it will cause anemia, احنا خرجنا شوية عن الموضوع, but it's extremely important in cases of trauma patients with a dropping hemoglobin. طيب. So what I meant by laboratory investigation specific for the subarachnoid hemorrhage is the level of sodium. And we know that we have the inappropriate ADH secretion, specifically present in cases of subarachnoid hemorrhage. So we should look for the level of the electrolytes. Now, radiology, we always start by non-contrasted CT scan. And non-contrasted CT scan in subarachnoid hemorrhage patients, we have many different categorization. They can be localized, they can be little, they can have a specific location, or it can be diffused, taking not only the subarachnoid, but the intraventricular system supratentorially and intratentorially. So the informations or the important information that you should collect from a plain or non-contrasted CT scan is, number one, does this patient has subarachnoid hemorrhage? In other words, did you see or can you see blood in the subarachnoid space on this CT scan? Well, statistically, the earlier the patient present to the medical facility for a CT imaging, the more percentage or the chance that the blood will be apparent or appear on the CT scan. And from studies, we know that if patients arrive within the first 6 hours, the chance of having the blood seen on a CT scan reach 99. So it is above 95% if they arrive early. This will decrease by time. So after the first 24 hours, it can drop up to 90 to 85 or 80. And within 5 days, it has been calculated that almost 50% of the patient will have a normal CT scan. No blood seen, no other evidence of a subarachnoid hemorrhage. So number one, we should ask the patient specifically, is this the first attack of sudden severe headache was in your life, or did you have it sometime before presenting to your emergency department? So number one, does he have or she has or she doesn't have a subarachnoid hemorrhage? Number two, and this is important, is the location. Where is the present or the location of this blood? Is it localized, confined to specific area? And why is this important? Or is it diffused like this? Any answer? So anybody can tell me what's the importance of, anybody can say why it is important to know the location of the blood?
Ali?
Yes, sometimes it indicates the location of the aneurysmal rupture.
Excellent, Dr. Ali. So, for example, if I'm talking about a midline, interhemispheric, basal, subarachnoid hemorrhage, then I will be thinking which aneurysm, can you guess? Or which location?
ACOM.
Anterior communicating aneurysm, we say always most probably. So if we are talking about lateralization to one Tilvian fissure or the other, then we are talking about which vessel?
Middle cerebral artery.
The middle cerebral artery. So this information is very important when you are dealing with patients who are harboring multiple aneurysms. So if he has 2 or 3 aneurysms and then he presents with subarachnoid hemorrhage, we want to know which one has bled, because you want to start with treating the one which is causing the symptomatology now, especially if you will be using endovascular techniques, and sometimes we need to use antiplatelet, not one, but a dual antiplatelet. So it will be very dangerous, very lethal to start treating the unruptured one and start the patient on antiplatelet. The patient might have another bleed which might be fatal. So number 1 is multiple aneurysm. And anybody know how many percentage or what's the percentage of multiple aneurysms? Almost 20%. This is a high number, and most of those who are harboring a middle cerebral artery aneurysm, we call it mirror image aneurysm. So the right MCA, they have the left MCA. So always look for multiplicity. The other thing, not only aneurysms, but patients with an arteriovenous malformation might have an addition or a presence of an aneurysm also. And then you want to know whether the AVM has ruptured or the aneurysm. So location is important. The other thing is, I want you to look at this image and name for me the type of subarachnoid hemorrhage for the seniors, لو سمحت دكتور. What do we call this type of subarachnoid hemorrhage? We said one of the causes of subarachnoid hemorrhage is called the aneurysmal perimesencephalic hemorrhage. Right. So once we look at this image, again, we should think about perimesencephalic hemorrhage, but we should not stigmata that patient as non-aneurysmal perimesencephalic hemorrhage until we continue on the investigation, the same as we start with anterior communicating possibility, middle cerebral possibility, posterior circulation possibility. So any of these images should be dealt the same. And don't think from the beginning that this is a non-aneurysmal. Why? Because of the location around the perimesencephalon or the midbrain. So location is important to evaluate in your initial non-contrast CT scan. Well, other information to gain is the presence of edema, the presence of hydrocephalus is important because the patient might be stable, but he deteriorated because of enlarged ventricle. So if enlarged ventricle, then the patient might have increased intracranial pressure. So we prefer to insert very controllable and external ventricular drain to control the ICP. On the other hand, in some situation where you will need to use the endovascular management, and we said that sometime we will start the patient on dual antiplatelet. So you want to insert prophylactically an external ventricular drain before you start the patient on antiplatelet or anticoagulation. So knowing hydrocephalus for the management or for prophylactic management. Ischemia and vasospasm, as we said, classically has been said that it will start after the 3rd day. But from our personal experience, we have seen it from the first day, and others have seen it also the same. So patient might present with subarachnoid hemorrhage in addition to a ischemic changes already present on the non-contrasted CT scan. So we need to know from the beginning how are we going to manage these patients. And for prognostication, because if I have seen a patient with a localized subarachnoid hemorrhage is totally different than if I have seen it involving bilaterally, supratentorial, and the infratentorial compartment. And we will come later to a grading system that we use on the CT scan. At the present time, anybody can name it for us? Intermediate. ما هو سينيور ولا جونيور. خلينا نقول third year.
بتعيد السؤال مرة ثانية بالتفضل، كان في تقطيع؟
السؤال أو المقطع؟
لا السؤال لأنه في تقطيع شوية.
I was saying that on the CT scan, when we see it, one of the evaluation that we have to grade the blood or the subarachnoid hemorrhage on the CT scan. So what do we call this grading system?
We received multiple answer على الشات. Modified Fisher grade.
Yeah, so if it is not modified, also we still use the Fisher grading system. So excellent. We use the Fisher grade or modified Fisher grading system. Fine. Let's go back to our case. She came after 10 days from her initial subarachnoid hemorrhage, and this is her CT scan. To tell you the truth, we've seen all the cuts, and I could not see an evidence of blood, whether in the basal cistern, intraventricular, or in the cortical subarachnoid space. So let's say it later. I have put this really case specifically. She is a patient who is highly educated. She had twice attack of sudden severe classical presentation of subarachnoid hemorrhage, and she was seen by her colleagues, people who were keen to help her and diagnose what she has. But in spite of that, she was missed to diagnose. So imagine a patient who is coming alone in the emergency room, nobody knows him, illiterate, and then having the same presentation. So this is a message for all of us that we should really, when we are in the emergency room, evaluate patients with a proper history and examination so that we don't miss those lethal, fatal causes patient might be presenting with. And in addition, this patient, 10 days, so she arrived with a normal CT scan. So what can we do to prove? One of the causes can be psychiatric. She doesn't have any subarachnoid hemorrhage. So how can we prove that the patient really had blood in her subarachnoid space? Other measures to prove.
We have some answers here. Almost all of them, they mentioning that LB for CSF study.
Any other answers? Any other than
we have angio.
Okay, so طيب, any other answers?
CTA, gradient echo. This is all from the chat.
Okay. So,
CTA
and DSA, digital subtraction, angiography, and you said lumbar puncture. They are they are all correct. The lumbar puncture will look for the presence of blood or the blood degraded, which is the xanthochromia and bilirubin in the CSF. So usually it is not in the first 24 hours after the ictus, because these changes will take time until it appears in the CSF. But CT angio and DSA is going for the diagnosis of the underlying pathology, but not for the presence or absence of subarachnoid hemorrhage. Yani, for example, if we did a DSA, the patient might have an aneurysm, but how can you prove that he had a real bleeding at that time? So one of the things is that you can rely on MRI. We don't do it most of the time, but flare image, MRI, in the period after the first day, and after 24 hours, the hemoglobin has already degraded into heme and globin, and then bilirubin and biliverdin. So it will give you the oxyhemoglobin changes on the MRI, specifically if you look at on the flare imaging. So yes, we do, and in this case specifically, I did an MRI and it was positive for oxyhemoglobin in the subarachnoid space. Why we don't go for lumbar puncture from the beginning? Lumbar puncture, in the first 24 hours, if the patient arrived to the emergency room and CT scan done immediately within 6 hours, as we said, it is very diagnostic of presence or absence of blood. So we don't need to do lumbar puncture. Number two, lumbar puncture is not without any complication. It's still a invasive procedure. The easiest or the least is hypotensive headache. So the patient presenting with the subarachnoid headache, and then you do the lumbar puncture, decrease the intraspinal and intracranial compartment CSF, and he will continue to have a severe headache, nausea, and vomiting. So yes, it is a measure, a method of doing and proving or disproving the presence of blood, but we don't, nowadays, we don't do it as a first option. Still, it is valid. So we did plain CT scan after taking a proper history and examination. We did an MRI, and then we evaluated the CT scan for the location and all the information that we needed. So all this information, you should collect it and then start thinking of what's next. So grading of the subarachnoid hemorrhage has been started since the 60s. Many grading system has been put, but the latest and the one that is used nowadays are, and most of the seniors should know, the Hunt and Hess. The well, not most, all of the seniors and most of the juniors should know the Hunt and Hess grading system, the WFNS for subarachnoid hemorrhage grading system, and as your colleague mentioned, Fisher grading system. Why are these important? We have to know what is the clinical situation or the clinical grade of this patient, because by this we can assess the severity. You can communicate with others. I can call somebody else who I would like to refer a case for him and say, I have a patient with Hunt and Hess 3, or he has Fisher 4. Then he will be also thinking the same as I am thinking about the severity, what does he need, or how will the condition of the patient on arrival be. So communication with others, planning of the management method, and broadly, and we can discuss it in another session, we have two methods: the microvascular open method and the endovascular method. And sometimes we lean toward one rather than the other, depending on the grading system or the grade clinically the patient is in. We can, by grading the condition of the patient, we can follow the patient from admission on the second day, the third day, and so forth. And it's a prognostication value because it has been numerically proved that with grade 4 and 5, whether it is on the Huntington HIS or on the WFNS, World Federation of Neurosurgery grading system, it has a very bad prognostic and average survival rate as compared to grade 1 to 3. So this will indicate for me what will the patient do in the next few days. And by having all of this information, I can communicate with the patient if he is conscious or with the patient family and plan with them what will be the next step of their relative. So we collected the information from the history, clinical examination, laboratory, and whether it is plain, a non-contrasted CT scan or MRI. So what's the next step? We would like to know the source of the bleeding. And you already mentioned that we can do complete tomography, angiography. We can do at the same time we did an MRI, we can do an MRA, and this can be done without giving any contrast, which will save the patient contrast material being injected, and still the the gold standard method is the digital subtraction angiography. So this is one example of a angiography. I will tell you that this is the right side, this is the left side. Any of the seniors, most seniors, can describe to us this image. Alaykum assalam wa rahmatullahi wa barakatuh.
So we have an ACOM saccular aneurysm pointing inferiorly.
Excellent.
And I'm seeing also some stenosis in the left A1, if I'm correct.
Yeah.
Sorry, the A2.
Okay. So as a hint, Dr. Eid والحاضرين, when you are first with an examiner, ما هو لطيف زيي, لكن those examiners who will put you in the corner, don't start with a full diagnosis until you are sure. So you said, I have a saccular aneurysm. الثانية صحيح, but the first one, so be careful when you say words. Start gradually, describe what you have. Describe number one, and then give the diagnosis. So correctly you said, I have an aneurysmal dilatation, which is pointing inferiorly. ما احنا عارفين is pointing anterior or posterior. And correctly you said that, although it is not seen very well here, hidden, but there is stenosis of the left A1. What else? أنا كنت بأشر هنا, I thought that you meant this. We also do have stenosis and strictus of the right A1. So this condition is not a saccular aneurysm, and it is a dissecting aneurysm involving the A1 segment on the right side. So I brought this image specifically for you to say that CT angio, it was done properly. If your technician can give the injecting, the timing, the acquisition properly, and not giving you the نسميها macaroni spaghetti of arteries and veins at the same time, then it is very good image. And sometimes if I say like this, I will not need a further investigation, and you can depend on the CT angio in our practice. So number one is a CT angio that will evaluate pathology. Use MRI, and at the same time, we said that you can do an MRA without giving contrast. So this is an uncontrasted MRA, and at the same time, you can do a vascular wall study. So this is an additional benefit of doing an MRI in specific cases like this. Another dissecting partially thrombosed aneurysm involving the pericallosal artery that we can study the wall itself. So MRI have an additional benefit of studying the wall of the vessel, which is vascular wall study. Now, the classic, the standard, the best till now information can be gained by digital subtraction angiography اللي هي مخفية تحت الصور هنا, whether it is 2D, AP, lateral, obliques, and so forth, or now the modern angiography have a 3D acquisition digital subtraction angiography that can show you a very exact images of this dissecting aneurysm that is involving an anterior cerebral artery distally. So is still the gold standard for vascular pathology, including aneurysms. طيب, we've seen the CT angio, we've seen an MRA or a digital subtraction angiography. What are the information that I need to gather about the aneurysm to make me able to give the proper decision? Decision is, what is the management? Is it endovascular or microvascular? And these are two broad categories. But when we come to more detail, even the endovascular, is it only simple coiling, balloon-assisted coil, stent-assisted coil, or is it a flow diverter? We cannot put a coil there and so forth. On the other side, is it a single clip application? Is it multiple clip reconstruction for the neck, or you need a major microvascular procedure to be done? So information include the aneurysm shape. So is the aneurysm smooth outline? Is it balloon, as it is said, or it has irregularity? So if we have irregularity, we call it daughter aneurysm, a blip that is coming from the main or the major dilatation. And most of the time, if not always, this blip is the source of the bleeding. So this will give you an idea whether you are exposing the aneurysm at the microvascular session, or you are introducing coils. You have to be careful from this blip not to rupture prematurely. The size of the aneurysm, and how do we classify the aneurysm according to size? We classify it into small, less than 10, up to 24, medium, 25 and higher. This is a large or giant aneurysms. And there are other classification systems about size, but this is the most common used. These information should be gathered not in one angle, but it should be at least AP and lateral. We should know the angioarchitecture of the neck. A neck that is larger than 4 millimeter, whatever is the aneurysm character, whatever is the aneurysm, other measurement is considered as wide neck aneurysm, and you should have a special management treatment for that aneurysm. An aneurysm neck to dome ratio should be taken in consideration, and the maximum diameter of the aneurysm in two angles, AP and lateral, should be also calculated. This is about the aneurysm, but also if you are attempting for micro or endovascular, you need the parent artery. So I need to know the artery itself, what is the size and how does it communicate with the aneurysm. Is the branching arteries, are they involved in the aneurysm, whether in the neck or in the dome itself? This is highly important so that you don't embark on management and then instead of benefiting, you would do so angio architecture information from these aneurysms. Now we collected all the informations and we are ready to manage this patient. Management actually start from the emergency room. As we said, you will stabilize the patient. You did the non-contrast CT scan. You found that the patient has hydrocephalus, increase intracranial pressure. Then we will start immediately by releasing the ICP with a controlled fashion, external ventricular drain, and not letting CSF to drain fast, because theoretically there is a risk of change in the pressure between the intravascular and intracranial, and this change will lead to rupture of the aneurysm. So when we put the EVD, we let it drain very slowly, drip by drip. The important balance to have is between treating the aneurysm bleeding or rebleeding and the risk of the vasospasm, because at times, let's say the blood pressure, you want to have good blood pressure and elevate it for the vasospasm, but this can harm the aneurysm, and that's why immediate and immediate management for the aneurysm to secure the aneurysm or obliterate it so that you get rid of one problem, which is the rebleed. And this can be done again by either microvascular or endovascular methods. And then you will direct your effort toward the other phase of the problem, which is preventing or treating the vasospasm and any associated problem that is occurring with the subarachnoid hemorrhage, vasospasm, the hydrocephalus, cerebral edema. These will cause increase in intracranial pressure. Seizure should be prevented, especially which aneurysm? Which aneurysm are or carry the highest risk for associated seizure? Aneurysm location,
MCA.
highest, the middle cerebral aneurysm, and that's why once I see Sylvian fissure, even before we diagnose the presence of aneurysm, but once we see a Sylvian fissure, subarachnoid hemorrhage, then prophylactically we start the patient on anti-epileptic measure. The late cerebral ischemia is the leading cause, if it appears, is the leading cause of in cases of subarachnoid hemorrhage, even if the aneurysm was properly, elegantly treated and managed. Other factors that might aggravate the clinical condition of the patient with subarachnoid hemorrhage is fever, and always control the temperature of the patient, the presence of hyponatremia, and the condition of neurogenic stunned myocardium, which can mimic highly the presence of MI. Even troponin can be elevated in those cases, and that's why you are working in conjunction with the not only the intensivist but also with the cardiologist in these cases to prevent the presence really of a true MI, and it's not only the association with. So So the management, as we said, starts by preventing the rebleed. And when I say early, it's immediately once the patient is morning, he should be done in the same day. I'm talking about the ideal situation, which I hope that we have. Or if they arrive late afternoon or night, they should be done next day. So the early management means up to the first 72 hours of subarachnoid hemorrhage. And this will allow you to manage the prevention of vasospasm. Now, immediately once the patient is in the emergency room, managing the blood pressure is very critical, because before you secure the aneurysm, you have risk of rebleeding. So we cannot let it go high, but you cannot induce really hypotension. So knowing that, you will start some medication that will lower the blood pressure, namely nimodipine, preferably that you discuss with your intensivist, the dangers of lowering the blood pressure, and it should be controlled very gradually. But once you secure the aneurysm, then we prefer to have the systolic blood pressure around 160. Well, historically, antifibrinolytic treatment like tranexamic acid was utilized, and nowadays it has been coming back into fashion. I don't have any experience with that. The management of vasospasm is in two sections. Prevention is better than cure, but I can tell you from the more than 20 years of cerebrovascular management, you cannot predict, even with all of these classification, grading system, patient coming in a very good condition initially, that you cannot predict that he will have vasospasm. So we always gear toward prevention of the occurrence of vasospasm, which can angiographically or radiologically can appear in up to 70, and in some of the studies up to 90%. But this is not what we care of. We care about the clinical vasospasm, because we have discrepancy between both terms, radiological and clinical. Sometimes they do occur together, but at times you do have radiological vasospasm without any clinical effect, and the vice versa. Sometimes clinically, and when you do the angiography, you might not find large vessel vasospasm. So how do we prevent? Number one, you should open your eyes very widely, instruct nurses, ask politely the intensivist that we should have very frequent neurological examination, and we mean full neurological assessment, even down to 30 minutes, or if they cannot, 1 hourly, as we do by Glasgow Coma score and by the NIH scoring system. Well, I was using the transcranial Doppler. It was in fashion. It's not a specific number, but it is the change. So you need to measure the transcranial Doppler velocity. Specifically, it works very nicely on MCA location. And then if the patient showed any change from his specific baseline, this is a very indicative of vasospasm. Still, we need to have confirmatory tests. We can either do it nowadays by the MRA, CT angiography, or immediately we go for the digital subtraction angiography that will have both diagnostic as well as therapeutic, as we will mention in a minute. Now, preventing vasospasm traditionally and still until now, the main two methods that are indicated is to prevent dehydration, not overhydrate, prevent dehydration, and nimodipine, which was in a trial since the 1983, where they found a very dramatic difference between those who have given placebo or for nimodipine for the occurrence of severe neurological deficit, and since that time it has been back in the recommendation guidelines. Actually, nimodipine is not a vasodilator, and we should know that it is a cerebral protector rather than a vasodilator. Classically, we used to hear about the triple H therapy, hypertension, hypervolemia, and hemodilution. Now, what we actually utilize mainly is the hypertension. We should not allow the patient to go into dehydration. He should be at least euvolemic, but without severe hypervolemia because of the associated, especially with elderly age, with older age group, pulmonary edema, and so forth. And the hemodilution, yes, it can improve the cerebral blood flow, but it will decrease on the oxygen carrying capacity, so we don't use it anymore. Other measures have been tried in studies. They go on, off, like magnesium, like statins, like nicardipine. Even they manufactured nicardipine pellets that we used once you secure the aneurysm. Then we put it on the artery at the area of the subarachnoid hemorrhage, and they did not find that a real benefit compared to nimodipine. Now, the other side is if vasospasm have occurred, then you are facing another scenario of trying to prevent the ischemia, infarction, and the neurological fast deterioration. So the management for vasospasm, the active management of vasospasm is endovascular. Now, previously, we used to say, once you open, you clean the subarachnoid space as much as possible from the blood, but this did not actually statistically properly showed the required benefit. On the contrary, sometimes it has irritation on the blood vessel that you will induce irritation, vasospasm, while you are removing the subarachnoid blood. Other trials where lumbar puncture and lumbar drain over a few days, or the external ventricular drain, including the installation of steroids sometimes, and so forth. But the actual difference has started when we started using the endovascular management, and they are of two types: either the active mechanical opening of the spastic artery, and this is done by a balloon angioplasty. So we introduce the microcatheter with a balloon. This is called balloon microcatheters into the spastic area. But this is only done for the proximal arteries. That is intracranial internal carotid artery, the M1, A1, the vertebrobasilar system, and the P1 segment, which is the posterocerebral artery for the posterior communicating artery joint. So these arteries, yes, they are large enough to accommodate the balloon catheter, and number two, they can hold the pressure that you will apply to make the angioplasty. They are excellent in that they will be long lasting, so they will not need re-treatment, like in these cases of the middle, anterior, and terminal ICA and the basilar, almost most of the basilar artery. Now, when we talk about the distal, fragile. If you try to dilate them with a balloon angioplasty, they might go and rupture. So you have to be careful and use the other modality, which is the intra-arterial. Again, we put a microcatheter until we reach the site of the vasospasm, and then we start giving either nimodipine intra-arterial or verapamil or other options, but what I'm using is nimodipine and verapamil. The good thing is that it really almost always works immediately. But on the other hand, it's only the half-life of the action of the medication, and then it starts wean off and the vasospasm recur. That might necessitate another session or a third session. So I wanted to show you our patient, which is the patient we started with, the severe subarachnoid hemorrhage. After we found that she does not have a blood on the non-contrasted CT scan, we did a CT angio, and as you see, this is the right side, this is the left side, internal carotid artery until you come for the supraclinoid level, that is intracranial, after passing the cavernous segment, and you have on the right side a fusiform enlargement of the artery. So we knew that the patient has fusiform aneurysm. We prepared her for endovascular session, and then we did a digital subtraction angiography, and these are the beautiful views that you see, and the one under the photo here is the 3D digital subtraction angiography, and you see this segment is, what is this segment of the internal carotid artery? Just came out of the cavernous and going intracranial. So what do we call أي أحد متبرع? Let's say seniors. Let's say seniors.
We have an answer على الشات, ophthalmic.
Yeah, so this is the ophthalmic segment of the internal carotid artery. We started looking at the angio architecture. What's the dangerous remark or finding in this aneurysm? اللي قلنا once we said we wanted to do the angio architecture evaluation. So who can tell me? Yes, doctor? Yes, so the blip, you see, this is the large aneurysm, but we have this small, tiny blip, which is the weakest point of the aneurysm, and most probably this is the area where it bled, and you can see it in another view. So this aneurysm, we can treat it by microvascular techniques, but it necessitates several steps. It's a longer procedure. Now with the presence of endovascular options, all we call it paraclinoid, ophthalmic segment, and the adjacent areas are initially or primarily treated by endovascular method. And because it is a large aneurysm and involving the wall of the artery also, so it cannot be a simple coil, and this patient was treated by flow diverter. So we started here of dual antiplatelet, and this is one example, that's why I brought it, of the cases that if you think that you will need an external ventricular drain, you should do it before you start your dual antiplatelet regimen. Now, coming back, after all of this journey, do you think that our right about saying to the patient, it's a time bomb? Personally, I think yes. But we advise that we should be very careful, very gentle, very nice when giving information to the patients, whether they are illiterate, simple people, or highly educated, because a patient is a patient, and at that time you should not consider him as a high educated engineer or physician or whatsoever. So we should have a way of putting facts, but very gentle and smooth for the family and for the patient individual. جزاكم الله خيرا. إذا كان عندكم أي أسئلة أو استفسارات تفضلوا.
We have a question about from Eid. What's your opinion about Milrinone for vasospasm?
About?
Milrinone for vasospasm.
Milrinone. Well, it is present in the literature, but personally, I did not use it, and I don't know how does it work actually.
And we have a question, what kind of flow diverting stent do you use?
What flow or what is flow diverters?
What kind of flow diverter?
Oh, what kind? Well, you have different companies. Huh? You have Mercedes, Benz, you have Jaguar. So in flow diverters, they all work. So we have one type is called silk, the other is pipeline, the third is thread, and they all, in my hand, they all work almost the same. One has some different over the other. For example, if you are looking for visibility on the angiogram, then I go for thread or silk. If I have a aneurysm at a small artery, then I will go for silk. Why? Because it has the smallest silk flow diverter that go into small micro catheter. So I don't need to have a large micro catheter to insert. And if I'm looking like this obstetric and gynecologist physician, we treated her in the acute stage. So I needed to start antiplatelet. And we cannot start antiplatelet in the acute stage. Why? Because of the risk of rebleeding. So pipeline came with a new philosophy, and it's called pipeline shield, that they claim it is safe to put the flow diverter only with the single antiplatelet, which is aspirin, and you don't need to give another antiplatelet. So in these cases, yes, I use pipeline. So this is in summary difference between the different flow diverters.
Faris?
السلام عليكم.
عليكم السلام ورحمة الله وبركاته.
يعطيك العافية دكتور باسم، محاضرة جميلة. Actually, I have 3 questions لو سمحت. الأول, which is more sensitive to detect subarachnoid hemorrhage? Is it the LP ولا the MRI? السؤال الثاني لو سمحت, in this cases where I cannot use the pipeline, when is the suitable time to start anticoagulation in the process of putting a flow diverter later? السؤال الثالث لو سمحت, ممكن تساعدنا في scheme كذا to algorithm to know what is the risk of rupture for different kind of aneurysm? يعني how do you usually, you personally, how do you usually think about it? يعني you start by the location ولا size ولا كذا, just to come up with an idea during counseling the patient إنه the risk of rupture is this or that. شكرا.
So أنا اكتشفت الآن إنه ذاكرتي ضعيفة. إيش السؤال الأول يا دكتور؟
السؤال الأول, which is more sensitive, ال MRI ولا ال LP to detect late presenting?
Or MRI. Now, yeah.
LB ولا MRI? Yes.
Yes. Yeah. So they are both very sensitive when you are talking about the late studies. Late study, which I mean is not immediate 24 hours. Both of them might be negative, although the patient has subarachnoid hemorrhage. And that's why we don't perform them in the first 24 hours. Now, if I have MRI, even if they have a less sensitivity, I will start with MRI. Why? Because it is less or it's not invasive, and you save the patient from a lumbar puncture. So start with MRI. This is personally. I start with MRI. If it is still negative, we will go for the lumbar puncture. And number two is which aneurysm do I think is more risky?
لا السؤال الثاني كان دكتور الله when to start anticoagulation لو ما عندي pipeline وبدي احط flow diverter and I need to start dual antiplatelet. When is the right time to start, keeping in mind the patient جايني بسبارachnoid hemorrhage أصلا?
Yes, so and number one, try not to start dual antiplatelet if the patient is in the acute stage. In other words, if I don't have that kind of flow diverter in this patient, I will do something else, and that is called dome packing. I will only pack lightly, gently, few coils with balloon assisted. So you will put the balloon, put some coils that will close the area that bled, which is the upper part in this aneurysm, and this is called partial dome packing. Let the patient pass the first 2 weeks, and then I will take him again, start the dual antiplatelet and put the flow diverter. This is one method that if you can do it, then we will start. Other times, the neck of the aneurysm is very wide and you cannot safely deploy even 2 or 3 coils in the area which is at risk of re-rupture. So this situation, we take the patient to the angio suite 2 hours before going down. 2 hours before going down, we give the patient a loading dose of both antiplatelets depending on what you have. Clopidogrel, which is Plavix, and aspirin. And then immediately take the patient for the flow diverter. Third, that we load the patient on table. So the patient is on the table. You started your endovascular procedure. I pass the microcatheter. All are in place for the flow diverter. I'm sure, inshallah, there is no limitations from going into the region, and then I load the patient with the dual antiplatelet. Or we give the IV antiplatelet, and this will be continued for 24 hours while the permanent clopidogrel and aspirin will take over the job. So these are the 3 methods. Which do we use? I use all the 3, and it depends on each case-by-case decision.
Dr. Bassem, we have a couple of questions from attendees. From Muhammad, what is your view about premesencephalic plus subarachnoid hemorrhage entity? Should we treat it like the usual premesencephalic?
You mean non-aneurysmal perimesencephalic hemorrhage?
Yes, with subarachnoid hemorrhage.
But this is subarachnoid hemorrhage. I didn't understand the question. When I say perimesencephalic, it is followed by perimesencephalic subarachnoid hemorrhage. It is subarachnoid hemorrhage, but it is around the area of the midbrain, and that's why they call it peri-mesencephalic. Now, this is a very special situation. If you did the CT angio, if you did a digital subtraction angiography, if you repeat it and you did not find any cause or etiology, including what we call bleb aneurysm or microaneurysms with the 3D DSA. If all these have been rolled out, usually the outcome is very, very good. So what I mean by the outcome is the patient clinical condition improvement dramatically fast compared to the usual subarachnoid hemorrhage. And these patients usually don't stay in the hospital for more than 2-3 days after the proof no aneurysm as a cause.
We have another question. Dr. Bassem. There's a question, have you noted any increased clotting events with silk? And do you keep them in dual antiplatelet longer?
Yeah, you mean, if I understood the question, is there any difference between the antiplatelet regime of the silk, the pipeline, and the thread, or any others? Personally, I did not find a difference between the three. The only thing is that the special issue is the use of the pipeline shield, that I will only use aspirin in a special situation if I need it. If I can use the dual antiplatelet, we always prefer it. Why? Because up to 14 to 20% of those patients treated by the flow diverters, they have the complication of thromboembolic phenomena, and thromboembolism or thrombosis, instant thrombosis, is not an easy thing to have, and that's why we have to be as careful as possible. Now, the regime can go up to 1 year of dual antiplatelet and then for life on aspirin only. In some situations, like 6 weeks or 7 weeks ago, a child, 17 years old, with an aneurysm, treated with a flow diverter on antiplatelet, she started to have epistaxis and toothache. So the dentist wanted to extract the tooth. We evaluated the aneurysm, the stent is open, aneurysm is gone, and we stopped the dual Prelenta after 6 months only, not 1 year.
Prof, you answered the second part of the question, really, when do you drop the antiplatelet? We have another question. What do you think is safe time frame for securing the aneurysm in subarachnoid patient? And if you can direct us if there is any advanced evidence to support this, since we have some difficulties with some interventions that can delay the angio for up to more than 24-hour post-ictus.
My advice, I can see 99 number. The 99 should go into what I'm doing. I'm a hybrid neurosurgeon. This means that doing both microvascular and endovascular. So you will do your angiography by yourself. This is a problem, and I face it also in some institutions, some hospitals, that the radiologist will have to do the angiogram. Well, ruptured aneurysm, by definition, should be treated immediately. And immediate means, as we said before, if the patient came In the morning, he should have all the investigation and be done in the same day. Investigation include digital subtraction angiography if you need it. Or if he came at night, then he should have all the investigations done and the therapy next early morning. So if I answer the question, it should be done immediately. How do you convince your radiologist? هذه هي المعادلة الصعبة.
طيب بروف, we have a سؤال من بروف بعيسى. When you do a second angiogram, when the first angio was negative in premesencephalic or non-premesencephalic subarachnoid hemorrhage.
Yeah, so those who for example, that CT scan, Prof. عيسى جزاك الله خير على السؤال ويعني أرحب بيك ترحيب خاص أخونا الكبير. That patient in the left corner that I presented the mesencephalic blood, he had a proper CT angio, and I mean by proper CT angio, there is no contamination of venous to arterial phase. The CTA was very clear, including posterior circulation. Then I went for immediately, I went for digital subtraction angiography, and that was negative, including 3D DSA. Both were negative. I discharged the patient, brought her again in 2 weeks and repeated the DSA. So the protocol, if the first DSA is negative, I still do a second DSA, and if that is clear, then I declare her as a true perimesencephalic hemorrhage.
Could we use direct 2 EVDs in cerebral cistern to wash the blood and to prevent vasospasm? Could we use directed 2 EVDs in the cerebral cistern to wash the blood and to prevent vasospasm?
In the cerebral cisterns, yeah, actually, it was a fashion when I was in Japan. We used to put an EVD and then we let it for drainage in the cistern. So secure the aneurysm, clean the subarachnoid space from the clot that is there, and then put the external ventricular drain not in the ventricle but in the cistern. But at that time, we did not find any benefit. Studies after that also confirmed that it's with no benefit, so I'm not using it anymore for a long period.
We have another question. What is the risk in percentage for aneurysmal rupture post LB?
I don't know. And I said it clearly that this is theoretical risk. So personally, I did not face this rupture. Theoretically, textbooks, yes, it is mentioned that you should be careful. So this will not tell me that I should not do external ventricular drain, but it will tell me that I should be extremely careful when I insert the EVD, just in case this theoretical risk is true.
Okay. We have a question from Abdulaziz. Do you follow Huntington's grade to decide timing for intervention?
مرة ثانية لو سمحت.
Do you follow the Huntington's grade to decide timing for intervention?
If I understood from this question, he means grade 1 to 3 will be the early intervention, which is immediate within the first 72 hours. You should not exceed, or once the patient arrives to your service. And grade 4 and 5, you wait for the hope that they improve, or you will leave them until 10 days. Now, it's not only Hunt and Hess, it should be 1 plus 2 plus 3. So if Hunt and Hess is 4, I will look for other causes rather than the condition of the patient per se. For example, increase intracranial pressure, the presence of ischemia, the perfusion is not good, the ventricles started to enlarge, and then you need to insert an EVD and so forth. But in general, even in the low, this is a personal preference, even in low Hunt and Hess, I go for early treatment because at least I secured one problem, which is rebleeding. If the patient is going to improve and then he will have another bleed, then it will be worsened again. But in these situations, I will not go for an open microvascular intervention, but I will most of the time, if not always, go for the simple, quick endovascular management.
Yeah, thank you. The question, we face it many times. Sometimes we get a consult from OB-GYN regarding a pregnant lady, known case of unruptured aneurysm, asking about the preference in delivery mode. Normal vaginal delivery or C-section.
Now, arteriovenous malformations and aneurysm, if they are unruptured in a pregnant lady, they should be assessed case by case depending on the angioarchitecture. So if you tell me this is a small aneurysm, and small, I mean 3-4 millimeter smooth outline, I don't see any blip. It's a diffuse rather than a small blip. Then always I will advise for a normal delivery. Otherwise, we might even need to treat even during pregnancy. I had one lady who had an aneurysm, which but that one was ruptured, and we treat during pregnancy. But ruptured, and it was not like the question you asked, which is not ruptured.